Hello, everyone. Welcome. Thanks for joining us today. So we'll get started and people will just keep trickling in. So welcome. Bonjour, everyone. Bonjour à tous. Bienvenue and welcome to the last of 3 webinars Born Ontario is hosting this month to learn more about the readiness survey to collect and use social demographic and social determinants of health data. We will refer to these data as SD and SDH data or as health equity data. My name is Pascale Girouard-Frappier, and I'm the Regional Coordinator for Prenatal Screening Ontario, housed at Born Ontario, and I'm delighted to be your moderator today. I will also be joined by Alicia St. Hill, Executive Director at Born Ontario. Health equity is everyone's business at Born and infuses every sphere of our work. I'd like to acknowledge the 17 members of Born's internal Health Equity Advisory Group, whose contributions have made the dissemination of the SD and SDH survey and today's webinar possible. The chat function is turned off, however, the Q&A feature is active, so please make sure to click on Q&A at the top of your page. You may have to click on the 3 dots on the top right to find this feature and enter your questions here as we go. And as a start, we would love to know who's joining us today, so feel free to write your name and organization from where you're joining us in the Q&A. And with that, let's dive into today's session. So I would like to start by sharing a land acknowledgement. Acknowledging territory is only the beginning of cultivating meaningful and reciprocal relationships with First Nations, Inuit and Métis peoples and communities. Nous rendons hommage à tous les peuples autochtones de la région et de toutes les nations à travers le Canada qui considèrent Ottawa comme leur foyer. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. J'aimerais débuter en reconnaissant que la terre sur laquelle nous nous rassemblons est le territoire traditionnel des peuples Haudenosaunee et Anishinaabe, le peuple original de l'île de la Tortue. Reflecting on this land acknowledgement, Born is aware of and seeks to adhere to the principles of Indigenous data governance and supporting Indigenous sovereignty with access to information and health data. Safe self-identification and use of such data must first involve building relationships with Indigenous people, communities, and organizations, and supporting their health information needs. Through this survey, we hope to learn more about the efforts of our data partners in supporting Indigenous wellness and data governance. Ontario Health continues their consultation around Indigenous identity data collection. Therefore, they do not yet propose specific wording for these questions and answers at this time. We recognize these data as part of a whole person's identity, and we acknowledge that these are missing in the current guidance, and we're asking in the survey, how would you or how do you approach collecting Indigenous identity information? You may be wondering why the survey was shared with all of our data partners earlier this month and why we're asking so many questions regarding your organization's current SD and SDH data collection and use practice. So we've invited you today to our webinar to ensure we share the context behind this initiative and provide you with the following insights. Why are we launching into the collection and use of SD and SDH data? What insights are we hoping to gain from the dissemination of this survey, and a few tips on how to fill the survey? How do we intend to use the results of the survey? And finally, we want to answer your questions regarding the survey and this initiative. Further, we're excited to be joined by care partner guests, Alexia Singh from Ancestral, hence Midwives, as well as Dr. Ian Zenlea and Dr. Dianne Fierheller from the Institute for Better Health, from Trillium Health Partners. And we are also, if you're interested to hear about the work of our past guests who have joined in earlier webinars, we will be circulating a compilation of the webinars in the coming weeks. So let me now introduce you to Alicia St. Hills, Executive Director at Born Ontario, and visionary who's leading our organization in achieving our mandate of facilitating and improving care for all.
Thanks, Pascale. Hello, everyone, and thank you so much for joining us today. I'm Alicia St. Hill, Executive Director at Born Ontario, and it's an absolute privilege to be here with so many of you dedicated care professionals and administrators and people who are just interested in advancing equity in our health system. Born was established to collect, interpret, and securely share high-quality data that informs care. So from system planning to the individual care decisions. As a prescribed registry under HIPAA, we work across the continuum of care with many partners, some of you here today. And this broad reach helps us to reflect families' lived experiences and identify gaps and inequities in care. Our Prenatal Screening Ontario program, a key part of our program here at Born, is originally focused to screen for genetic conditions like Down syndrome. And the lab that performs multiple marker screening, testing that's done by over 70% of pregnant individuals in Ontario today, has provided us with rare racial sociodemographic data. And while imperfect, this data has helped us to start to apply a racial equity lens to care and outcome analyses that we perform. Its limitations, though, highlight the need for more inclusive data that reflects Ontario's diverse population and intersecting identities, including language spoken, newcomer status, race, housing and financial insecurity, disability, and gender. But today's efforts to learn about and use SD and SDH data go far beyond the data collection alone. We're actually about connection, and the N in Born stands for network. And that's exactly what we are, a collaborative, province-wide network of programs, clinicians, researchers, policymakers, data partners, epidemiologists. Together, we've made some meaningful impacts in care and the evidence generation that is needed to have a learning health system around perinatal and child health. As we continue to use health equity to guide improvement, we'll ask some new questions. We'll take some uncharted steps together. We'll devise new approaches and leading practices. We'll uncover some disparities and we'll build solutions together to close them in care. Because the outcomes we seek to attain need to be attainable by everyone. And equity isn't just a side goal, it's central to our collective vision, the best possible beginnings for lifelong health. In today's conversation, we're accompanying our survey, the survey that's accompanying this presentation, are steps that we're taking to help make sure that our data, our systems, and the way that we measure care and outcomes actually reflects that truth. We're also aware, just like you see on the screen, this journey, many of us are on different paths in our organizations towards collecting and using sociodemographic data, and that's great. Our own journey at Born has been long and nonlinear too. And we began in 2012 with the launch of the BIZ, so this new platform that was bringing together data from multiple pre-existing programs. We collected information about primary language spoken of patients in childbirth and education level, but we placed limited focus on the completeness or capture of that data at the time. And early in our journey, we engaged with more than a dozen Indigenous health organizations and partners. And from those conversations, we heard how a registry could evolve to better reflect traditional models of care, support self-identification of Indigenous ancestry, uphold Indigenous data governance principles, including OCAP, and that would challenge us to do things differently. So these insights really helped, our thinking about how this data can serve communities. And internally, we built and sustained a culture of reflection and psychological safety with our internal health equity advisory group, formed in 2020. This multidisciplinary team helps us stay internally motivated and encouraged across the team to grow our understanding of equity, Indigenous sovereignty, reconciliation, and data governance. In fact, many of those people in that group help facilitate this webinar today. And keep us focused on how to apply an equity lens to our analysis and strengthen the policies that guide that work. So in 2021, we strengthened the advice we received from people with lived and living experience, but also branching out and creating an external health equity advisory group, still active today. In 2021, Born researchers published studies showing racial disparities in perinatal outcomes, even after controlling for certain other risk factors. These findings sparked new insights and hypotheses, and they continue to help us examine outcomes across socioeconomic lines, including recent work on postpartum mortality. And we're increasingly aware of the limitations in the available data. So we also know that publishing alone isn't enough. We're committed to bringing people together to understand why these differences exist, close the gaps in the reliable information to analyze equity, and to measure the impact of current and future interventions. And so we're actively working on building our internal capacity to do just that. Most recently, in 2025, our work with Ontario's Pediatric Diabetes Education Programs and PCMCH's Pediatric Diabetes Network, we've learned from local teams how to start safely and meaningfully collecting social determinants data from children and youth and their families. This work was shaped by thoughtful engagement with the care teams and families to ensure the process was respectful and secure. Now, early feedback's already showing us that it's helping tailor care in meaningful ways and reinforcing that the act of collecting this information alone can lead to a better experience and outcome. So I'm just going to take a few minutes to kind of frame the why around this, data for equity in perinatal and child health. So to improve the outcomes for all families, we need to understand the broader context of their lives, not just the biology or administrative data, but the social, economic, cultural context that helps shape their health and life in Ontario. And this does represent a bit of a culture shift in terms of how we've analyzed health data. It challenges us to move beyond traditional approaches and recognize that access to care isn't equally distributed and that there are numerous barriers to the best outcomes. We must ask ourselves not just how many are receiving excellent care, but who is not and why. And so for clinicians, including OBs, midwives, nurses, family doctors, endocrinologists like are on this call today, the sociodemographic information, especially when safely disclosed, helps us to tailor care to real and perceived risks for the needs of patients and their families. For example, if we ask patients to share their food insecurity concerns with us, clinicians and care teams are better positioned to help them navigate the available perinatal nutrition supports or other resources in the community, allowing our care models to better anticipate and proactively address issues that are going to influence pregnancy and child health outcomes, including things like low birth weight and high bleeding risk from anemia. Bleeding is a leading cause of perinatal mortality within the first 6 weeks after childbirth. So that's an area where we really want to focus. For programs from local to provincial, we can also use SD and SDH data to allocate resources to tailor our programming appropriately. So we know, for example, that hypertensive disorders in pregnancy are the leading cause of both maternal and infant mortality and morbidity, and these rates are rising. Then if we see preterm birth from preeclampsia in certain racialized groups or specific neighborhoods experiencing higher levels of deprivation, these insights can drive our collaborations and tailor our outreach into early prenatal education and messaging about low-dose aspirin and its safety, or screening services and other services in collaboration with the community. This kind of data-driven coordination can help us to ensure that the care reaches those who need it the most and how they best choose and can access it, while using our own system resources, including provincial programs like ours, to target our approaches to improvement. In multiple marker screening or multiple marker aneuploidy screening for fetal genetic screening that I mentioned earlier, we've used race to adjust the biomarker differences observed between populations for years. Our PSO program is now doing a deep dive to understand how these adjustments continue to affect screening outcomes. And we know that we need information beyond the lab requisition alone. We need richer intersectional data that must come from elsewhere to help us better understand the differences driving the use of race, and really whether race is a proxy for other underlying factors that affect screening performance more directly. Furthermore, the screening program, as we expand, we're looking at ways in which we too can collect and use SD/SDH data to learn more about who may be missing out on or using the services that we offer and improve our program quality. Community organizations as well can benefit. For example, Indigenous health organizations and community-based parenting programs can all use SD and SDH data to ensure services are culturally relevant and support key health issues. As Ontario expanded our RSV protection last year, understanding who makes up approximately 25% of infants who remained unprotected after discharge from the birth hospital is important. We need to understand the social context around them and what it means to future seasons as we tailor our approaches in partnership with clinicians, communities, and hospitals, and to be more responsive to family perspectives, values, and beliefs that may be impacting their participation in these programs. These kind of approaches can help us build trust and improve engagement with care. Researchers, including clinicians and social science researchers, also use our published insights to further explore disparities and can use the data that we have available beyond just the normal medical correlations and help us shed a light on some of the mechanisms, the structural inequity or discrimination that may be at play in perinatal and child health. And above all, we want to use and collect this information and this data to drive accountability. So without it, inequities can remain invisible, silent, poorly understood, unaddressed. And with an equity lens, we can track progress, identify gaps, and hold ourselves accountable to individuals and to the public, ensuring that equity isn't just a goal, but a measurable outcome. And the uses of our insights far extend beyond what we traditionally call the health system. Many of you here today know that health is influenced by more than what occurs within traditional healthcare settings. And where external factors play a role, like in many of the real world examples I shared before, it's our responsibility to raise them up as opportunities for improvement to government or others in positions to support better outcomes from life's very beginning. We've launched this survey to understand how practices and organizations across Ontario are engaging with their patients and clients to collect and use this data, whether it's being asked and whether it aligns with the questions and options that were proposed by Ontario Health in their guidance on collecting and using sociodemographic and social determinants of health data published last summer. And this will inform our work ahead as well. And we really want to thank Ontario Health for their leadership in making this provincial resource available to all of us. So today, we're inviting you to join in this learning opportunity. Whether you've already completed your survey or just learning about it, we're really glad you're here. And we're so thankful that you are partners on this journey alongside us. The survey is definitely going to help us to take a pulse on currently what's happening and the readiness across the system to collect and use this data. It's going to help inform our next steps from data collection to data governance and use, both for Born and Prenatal Screening Ontario and our partners. It's going to help us identify some leaders and some champions like those we have joining us on the call today, and some early adopters who can support peer learning and network building that's going to make important steps in these endeavors. It's also going to help us understand where support is needed. So to encourage the adoption of these activities that are leading practices for how we ask, how we collect, how we use and manage this data and make it available, and to engage families and individuals in what we're learning and how we can better support them. We also hope it helps us fuel partnerships. So the aggregated survey results will be shared with you all. It's also going to be shared with our partners, including the Equity, Inclusion, Diversity, and Anti-Racism Group at Ontario Health and the Provincial Council for Maternal Child Health, who are both focused on this type of work as well. And last, we hope that it's going to help us explore meaningful use and data exchange options for prenatal, postpartum, primary care, and child health. Some of the work that we have planned in our near future at Born will involve us using our unique registry authority to directly impact care and outcomes with digital health solutions and digital health information exchange solutions that will reach the individual and family and their clinicians, with a goal of improving the safety of care, care engagement, and access to timely personalized care and insights and information. So these same digital tools may be used safely and privately to allow people to share their sociodemographic information as long as it's well governed directly from those individuals who are receiving care. And so we've also asked questions in the survey to understand whether you would or your organizations would like to, or how you might envision using SD or SDH data that comes from other sources for your patients and clients who wish to share that data with you. So thanks for joining today and for your time that you've already taken or will take to tell us a little bit more about your journey. And I'll turn it back to you, Pascale.
Thank you, Alicia. If you have some questions for Alicia, feel free to share them in the Q&A section as we can start answering them as we move along in the webinar. The survey we have shared with you was developed following various community and partner engagement opportunities and was created, as Alicia mentioned, using OH's published guidance. We also piloted the survey with organizations and simplified it based on their feedback, since this was a little too long at the beginning, and we wanted to make it a bit more accessible. The topics shown here are reflected in the survey structure. You will see that sections 1 to 5 are for all respondents, whereas sections 6 to 10 appear only for organizations working towards or currently collecting SD and SDH data. The first question asks whether your organization collects SD or SDH data, who collects it, when along the care continuum is it collected, and how it's stored, and also perhaps what barrier might exist in collecting that data, such as limited resources or lack of leadership buy-in. Here are a few sections we were hoping to highlight. For example, in section 5 on data governance, we ask whether receiving SD and SDH data from other sources would be helpful and how your organization approaches governance. This helps us understand readiness to manage and ethically use sensitive data, as we know strong data governance is essential to build trust with patients and communities. In section 6, collection content, We're curious whether your organization uses Ontario Health guidance. The use of this guidance may support consistency and standardization in our efforts, data collection efforts. Even if you're unsure, you will have the opportunity to upload your questionnaire directly in the survey or email it to our team who can review and compare with the guidance. In community engagement section or section 9, we want to learn how community leadership is involved in your data journey and whether frameworks like EGAP, Engagement, Governance, Access, and Protection, a framework published by the Black Health Equity Working Group, or OCAP, Ownership, Control, Access, and Possession, copyrighted by the First Nations Information Governance Center, were considered in your efforts. This helps us support other sites in deepening community engagements as well. And finally, in section 10, we're interested in learning how this data is used or intended to be used to drive meaningful changes for equity deserving group. We know the call for action from communities has been loud and clear, and that's why we're thrilled to welcome this afternoon's guest speakers who are not only passionate about their work, but are making a real impact in their community. So please join me in welcoming Alexia Singh. Alexia is a registered midwife and clinical director at Ancestral Midwives. She's currently pursuing a Master of Science in Midwifery at McMaster University with a focus on culturally concordant care and its impact on reducing racial disparities in Black reproductive health. Alexia is passionate about advancing health literacy and creating equitable opportunities, particularly for Black and equity deserving communities. She's ecstatic about being part of an innovative program and that aims to provide a truly holistic approach to Black perinatal health and looks forward to supporting families through affirming and compassionate care. Alexia also contributes to the broader birthing community as a hospitalist as Oak Valley Health alongside Midwifery Unit, as well as professionally elected council member of the College of Midwives of Ontario. Alexia, thank you very much for being here today and welcome.
Thank you so much. Just give me 1 second, let me share. Okay. Can you see my slide?
Yes, we can see your slide. Thank you.
Lovely. Okay. Well, thank you so much for the, oh, hold on. Okay. Thank you so much for the lovely introduction. As mentioned, I'm Alexia Singh, clinical director at Ancestral Hands, and we're so happy to be here today to discuss how we're working to build trust and gather true experiences through the use of sociodemographic and social determinants of health data. So today's presentation will introduce AHM and discuss how and when sociodemographic and SDH data is collected and how it's used and our vision for the future. Ancestral Hands Midwives, AHM for short, is an expanded midwifery care model program which allows for midwives to work in different ways than the typical midwifery practice group model in Ontario. This new way of working has allowed us to focus our program on the Black community and work to increase access to midwifery care. AHM was approved by Ontario Midwifery Program late in 2023, and we started seeing clients in February of 24. We're a B3 nonprofit organization. And unlike most other EMCMs, we're not directly associated with community health centers, hospitals, or midwifery practice group, but we do collaborate with all of these types of organizations. We're a small but mighty team of 3 and 1 administrator, and we look forward to growing our team and increasing our capacity. We're located in the Malvern area of Scarborough, and our catchment area includes parts of Durham, Scarborough, and York region. This program was created as part of the solution to the Black maternal health crisis because the high contact, low intervention care that midwives provide can lead to better perinatal outcomes and experiences. We can innovate in maternity care to provide the Black community with care responsive to their needs. This means providing culturally specific education and programming that's tailored to the needs of our diverse Black Canadian population. And we recognize the value in racially concordant spaces, and having midwives that represent our community has already been seen to make a huge impact on client satisfaction, especially as it pertains to advocacy and understanding and support. Many of our clients express a level of comfort at our clinic that they don't experience in other healthcare settings. For example, just yesterday, or a few days ago now, a client came into our office and she really just stopped by to take a nap. She went on to ask us to check something that she had talked to her doctor about, but she had felt dismissed. And things like this, experiences like this, are what illustrate how our clients feel in our space, and that assures us that we're headed in the right direction. As a first of its kind program, we're still evolving and we're figuring out the best model for meeting client needs. Currently, we provide prenatal and postpartum midwifery care. We see clients at any stage of pregnancy and work with midwives or obstetricians who provide intrapartum care for our clients as we're not currently conducting births. We're an intentionally low volume clinic because we want to ensure that we don't compromise quality over volume. And our visits are regularly an hour to an hour and a half long so that clients have an opportunity to speak, be heard, and have their needs met without feeling rushed. We have partnerships with local midwifery practice groups, one other EMCM in different communities to offer intrapartum care to our low-risk clients. And then we work with a handful of obstetricians to provide care to our high-risk clients or our low-risk clients who opt in for an who desire an obstetrician. We provide supportive care to clients who come to us already having a care provider, but are looking for additional advocacy and support. And we work with other organizations such as Taibu Community Health Center and various perinatal care providers to help clients get the wraparound services that they need. Some of these services include primary health care, mental health support, doula care, housing, and legal support. And so we collect sociodemographic data with the goal of improving culturally safe, racially concordant perinatal care for the Black, African, and Caribbean community. We capture both quantitative and qualitative information so that we can reflect the client's real lived experiences. This allows us to tailor the care that we provide to their specific needs and also helps us determine how to prioritize care for equity-deserving groups. Formally, we collect this data in a few ways. So first at the initial intake before care begins, and then again through the client experience survey after care is completed. To improve response rates, we often offer the survey at 4 to 6 weeks postpartum on our clinic iPad, and we also use program evaluation surveys for clients who attend our prenatal education and infant feeding classes. Informally, we gather qualitative data through Google reviews and client testimonies, which clients are invited to share if they wish. And these stories often provide depth and context that formal surveys can't always capture. Oh, I'm sorry, I missed a slide for you here. Okay. So we use OceanMD as our platform for initial intakes. It connects to our EMR and allows easy access to client information, demographics, and social history. In terms of sociodemographic data, we ask about age, ethnicity, language, immigration status, income, and housing. And in terms of social determinants of health history, we want to know about clients' support systems, their mental health, substance use, safety, such as domestic violence concerns, and community resources that may be needed. And then we collect experiential data, which involves perceptions of cultural safety satisfaction with with perceptions of cultural safety and satisfaction with current and previous care providers. Did they have a sense of belonging, or did they trust their providers? Did they feel safe? Where we're a bit stuck right now is, and where we need a bit more community input, is deciding what direction we want this data to take us in. What is most important for clients and their families, and how can we leverage this information to meet their needs and identify gaps? It's important that we don't assume that we know the answers, because as clinicians, we bring a very different lens to the population, the people that we serve. So what you see here are screenshots from our client feedback surveys. We provide this using a Microsoft form, which draws on validated tools from the Birthplace Lab. They allow us to collect quantitative data on how autonomous clients felt in their decision-making and how respected they felt throughout their care. What has been most surprising is how forthcoming clients are with their stories. Racial concordance plays a big role in this. So when people walk in and they see themselves reflected in the art on the wall, for example, they feel safe enough to share experiences that they've never disclosed to anyone, especially not even a healthcare provider. For me, this stands in stark contrast to other spaces that I've worked in, where Black clients rarely felt the same sense of safety and openness right off the bat. We use the data that we collect for prioritizing care, ensuring that we're serving our priority population, understanding who our priority population is and their intersectionalities, and we want to know what the needs are without making assumptions. We want our clients to know that they're seen and heard, so continuing to use participatory research methods to gather information together with our clients is really important. We want to use SD data to continue to create a safe space for clients to walk into, whether it's at our office or our partners' offices. And this means data can help to guide advocacy and training where it's lacking between all of our partners. And it builds a compelling case to increase funding for more midwives and programming that's focused on Black sexual and reproductive health care. This will allow us to increase access to care for equity-deserving groups and help to improve individual health literacy and hopefully expand to providing intrapartum care to our families that's in-house as opposed to working with other folks to provide that component of care. And it's imperative that what we do with the data does not compromise what we have already built. As you can see that we already know through existing qualitative data, clients value more time to build connection and trust, especially in a system that systematically excludes them from quality care. We're not trying to reinvent the wheel. There's already a strong body of evidence documenting the disparities that exist in the Black perinatal health, and we don't need to duplicate or reprove those findings within our setting. Instead, our focus is on making sure our research and key performance indicators truly reflect the priorities and the experiences of our community. So our vision is to use born sociodemographic and social determinants of health data to directly improve care. That means shaping programs and services so they're responsive and culturally relevant. It also means building a consumer steering committee so community voices guide how the data is interpreted and applied. And with this data, we can evaluate our impact, identify gaps, and compare outcomes for Black clients to other groups, highlighting disparities and advocating for equity. As well, the data can fuel research and knowledge translation that centers Black perinatal experiences. Currently, we use multiple platforms to collect data. So OceanMD, as mentioned before, Microsoft Forms, and manually with Excel spreadsheets. And while each tool serves a purpose, it can be time-consuming and it creates challenges when trying to integrate or analyze information across systems. So we hope that Born can help us move towards a centralized space for data collection. Having one streamlined system would make it easier to track sociodemographic and social health data, reduce duplication, and improve accuracy. It would also allow us to generate meaningful reports more efficiently, share insights across providers, and ultimately ensure that the data we're collecting is being translated into better care and outcomes for our clients and their families. But we also need to proceed with caution. And as Lana James reminds us, data governance matters. Who owns the data, who can access it, and who gets to publish it. We have to ask if the data could be sold, repurposed, or even used against the very communities it's meant to serve. And we need to be clear on our intent. Because historically, race-based data hasn't been mobilized to support Black communities. So without transparent governance and true community leadership, this work risks reinforcing inequities instead of dismantling them. We're really excited for what the future holds, and we think there's a lot that can come from collaboration and community. And so we're really excited to see where everything moves from here. Thank you so much for your time, and I'm happy to answer any questions.
Thank you so much, Alexia. I think this is really a great example of how you use your data and really to support the community you're serving. If you have any questions for Alexia, please don't hesitate to share them in the Q&A section. We will make some time at the end of the webinar to take those questions. I will now turn it to Dr. Zenlea and Dr. Fierheller. I will just share my screen quickly. Well, welcome, Dr. Zenlea and Dr. Fierheller. My screens are not, my slides are not sharing.
Oh, we can see them.
Are you?
Mm-hmm.
Okay, great. Just waiting for my notes to share.
We can also introduce ourselves. That's okay too, Pascale.
My notes are not loading. I apologize.
Yeah, no.
Yeah, we'll do it.
Let us introduce ourselves. Ian will put the slides up. Yeah,
If
we'll
you wish to
transition.
introduce yourself, please. Thank you so much.
Thank you for having us. And
It's a
thank you for
pleasure.
sharing, Alexia. It was so great to hear about the work you're doing. So my name is Dianne Fierheller, and I am a scientist at the Institute for Better Health at Trillium Health Partners. I've worked as a social worker in pediatrics at Sick Kids and Trillium for many, many years. And collecting sociodemographic data was part of my training as becoming a social worker many decades ago at TMU, was Ryerson at the time. And so really happy to be here. I'm going to let Ian introduce himself, but we're going to co-present these slides. So he'll do that next. We're here to share a little bit of our work and our story out of the region of Peel around building a learning healthcare community model for women's and children's health in Peel, really about laying the foundation. Next slide, please, Ian. And so we're going to introduce our research program, which is called the Family and Child Health Initiative. I know we don't have a lot of time, so we're going to give snapshots. And then we're going to really focus on one of our projects, building a learning healthcare community model for women's and children's health. Next slide, Ian. So quickly, I want to take a minute to acknowledge the land. This is the Credit River in the region of Peel, where our work is situated. And I want to acknowledge the treaty lands and territory of the Mississaugas of the Credit First Nation, recognizing the Anishinaabe, the Huron-Wendat, the Haudenosaunee, the Ojibwa-Chippewa peoples, and the Métis. Next slide, please, Ian. And these are some disclosures on behalf of Dr. Ian Zenlea and potential conflicts of interest. And I really want to take a minute to acknowledge our amazing community partners. So we have a list of our Family and Child Health Initiative team. We are a community-based participatory research program out of the region of Peel at Trillium Health Partners. We could not do this work without our amazing community partners that we work alongside. And that includes organizations, it includes our public health systems, and the many children, youth, and families that we get to work alongside every day in our program. Next slide, please, Ian. So I'm going to start. I know Alexia spoke about the importance of participatory research and community research, and I'm going to read one of the quotes from one of our amazing partners, Angela Carter from Roots Community Services. She is a leader that has been doing work in many different spaces in our region of Peel and beyond. And Angela says to us about community partners research, Community partnered research isn't just about better outcomes, it's about justice. It's about saying to communities, you are not just a subject of study, you are a co-creator of knowledge, a holder of wisdom, and a vital part of any solution. As researchers, you have a beautiful opportunity. You can be the generation that does things differently, that leads with humility, builds with community, and centers equity at every step. The invitation is there. The question is, how will you respond? And I hope that we can all continue to think with these words as we move forward. A little bit about the Family and Child Health Initiative. We came together in 2018, really focused on how do we support the health and well-being of children, youth, and families and communities in the region of Peel. And for those of you that aren't familiar, the region of Peel consists of the city of Mississauga, the city of Brampton, and the town of Caledon. We want to deepen our understanding of the interconnected factors at the individual, family, institutional, and systems level that influence child, women, and family health. And we're really focused on action. We've heard from our community partners who we work so closely with that we don't want to do research that just sits on the shelf. So we're really intentional at co-designing, implementing, and evaluating interventions to support the health of children, women, and families in our communities. Next slide, please. And this is just a little snapshot of how we do that. And so another one of our partners, Baldev Muda, said to us, academic institutions need to rethink how they do research in partnership with community agencies. And so a big part of our work with FCHI is part of my role as a social scientist. I sit on many different community response tables in our region. That's what these figures are showing here, some of those. And these are cross-sectoral partnership tables that are really focused on identifying the needs of communities and creating action plans together. And the work that we're about to present today really came out of work alongside the Anti-Black Racism and Systemic Discrimination Healthcare Collective. And this is a group that I co-lead in our region. And the conversation around data and the need for data really came to the forefront. There's been advocacy for decades, but really came to the forefront during COVID-19 when the region of Peel was very much impacted and multiple communities were impacted and there was no data. And so our community leaders really advocated with the region and with the ministry to really make sure that this moved forward. And the work that we're presenting today has really grown over the years from that work. Next slide, please. So the project we're going to present today and some snapshot results, again, it is building a learning healthcare community model within the Women's and Children's program at Trillium Health Partners. And these objectives were to identify key partners and networks in maternal and child health care at Trillium Health Partners and across community services in Peel. We wanted to explore how community partners and healthcare providers can safely and efficiently collect and integrate individual level sociodemographic data. And we wanted to create a supportive environment for a learning health system by fostering partnerships and formalizing partner engagement. And I'm going to pass over to Ian now, who's going to dive in a little bit more to how we brought those objectives to life.
Thanks, Diane. Hi, everybody. I'm Dr. Ian Zenlea. I'm a pediatric endocrinologist and clinician scientist at Trillium Health Partners. I co-lead the Family and Child Health Initiative with Diane. We've been doing this work since 2018. You'll often see the two of us traveling together. We co-lead this program truly in partnership with our community and our other research staff. I'd also like to acknowledge that Sarah Abdullah, who is one of our team members, is also present on this webinar. Sarah led this work alongside me and Diane in the Women's and Children's program at Trillium Health Partners. So many of you may know that the Women's and Children's program at Trillium Health Partners is going through some significant changes. We are consolidating all of our inpatient acute care programming to the Credit Valley Hospital on October 8th. And this is a stepping stone from a multi-site system of care for women's and children's to still a large system of care, but moving towards our future Shaw Family Hospital for Women and Children, which will be opening in the early 2030s. And that Women and Children's Hospital will be situated within a larger Peter Gilgan Mississauga Hospital that will be about 22 stories high, one of the largest hospitals, I understand, in all of North America, at the current Mississauga Hospital site in Queensway. Our research institute, the Institute for Better Health, does work in learning health systems. And for those of you who aren't familiar with the learning health system, it's a healthcare framework that continuously integrates clinical data, research, and practice to improve patient care and health outcomes. It promotes a cycle of gathering data from routine healthcare experiences, analyzing it to generate insights, and applies those insights to make evidence-based improvements in real time. And our institution has conceptualized a learning health system as an engine with gears, with fuel and accelerants, and with moderators and brakes. And you can see that the key features of a learning health system include data-driven decision-making, continuous learning, collaboration with clinicians, researchers, people with lived experience who utilize health services, who we refer to as service users during this presentation, policymakers, all in shared learning opportunities and rapid implementation. So Dianne has used the term learning healthcare community, which is the title of our project. And a learning healthcare community essentially extends the learning health system by fostering broader collaboration and partner engagement beyond just healthcare providers and researchers. This model emphasizes the inclusion of people with lived experience, children, youth, and families, community organizations, and policymakers in the learning process. So really extending outside, sorry, I have a puppy in the room and he is getting agitated. Broader data inclusion, localized innovation, sustainable improvement, and enhanced collaborations. So with this learning healthcare community concept, we really are building the foundation. Give me 1 second, everybody. I'm so sorry.
It's all good, Ian, we understand.
It's like I have children, but then I have a 5-month-old dog who wants some attention right here. So he'll just be right down there. He's very cute. So sorry, everybody, my apologies. So essentially, the learning healthcare community is a model that we're really endeavoring to build at the Women's and Children's program at Trillium Health Partners, and within this new hospital as we're laying the foundations for that. So this project that we're presenting today is part of a broader initiative within Trillium Health Partners to consider the opportunities for us to collect sociodemographic and social determinants of health data across the institution in partnership with our community. Dianne and I had done some foundational work a few years ago through some funding that we received from the University of Toronto, where we engaged community providers in understanding who is and who isn't accessing primary care services in Peel. And through that work, we learned that many of our community agencies, who are primarily social services agencies, are already collecting socio-demographic data and data related to the social determinants of health. So we brought that thinking into the organization as our data governance committees, our digital health committee are thinking about how we, as an EPIC institution, that is our electronic health record, might start to use EPIC and the features within EPIC to collect data within our population health modules. Rather than just turning something on within a computer system, we really wanted to engage our broader community partners who've been doing this work in the community well for decades, and then our service users within our system, both outside and inside the walls of Trillium Health Partners, and then our service providers to understand what some of their values, needs, and preferences might be related to the collection of these data. We wanted to do this slowly, intentionally, and aligned with our principles around community engagement and community participation, which Dianne spoke to. And so we have conducted this work in 2 phases. The first phase was the foundational phase, during which we really engaged community partners in a series of workshops, and also community service users in these workshops to identify the key priorities for sociodemographic and social determinants of health data. We analyzed the results. We prepared a community report, and Dianne can put the link to the community report in the chat for all of you to see. And then we wanted, after taking this community approach and this community lens, to bring that thinking into the walls of Trillium Health Partners, and specifically within the Women's and Children's program. And we identified 4 key areas for engagement, thinking through planned care, being outpatient clinical opportunities, and unplanned care being acute care inpatient opportunities for how we might collect these information safely, meaningfully, honoring community needs and values, really respecting privacy, confidentiality, and understanding what the needs from an educational perspective and capacity building perspective of our providers might be, and how we might start to engage our service users and understanding the reasons why we might be collecting these data. And this is work that we conducted within the new year from January to June of 2025. And through all of this work, we've actually engaged through the course of this project over 160 people. Those have included 35 service users, 50 service users, so people with lived experience, 53 social service agencies, 55 THP clinicians and administrators, THP being Trillium Health Partners. We've engaged 10 municipal and regional employees and 9 other medical providers and administrators. And so all of this information has been distilled down for the first time, for the first phase in that community report. And then we are preparing a THP focused slide deck that we'll also use to share our results. And so what we've learned is that some of the key foundational elements that emerge through the qualitative analysis of these workshops is that it is critically important and really foundational, hence our naming this the foundational phase, that we intentionally work to build trust and transparency with our community, that we think about institutional and logistical factors that impact data collection. So really thinking about the timing of data collection, when is it appropriate to ask some of these data elements, who should be asking, what training they should have in order to be comfortable asking, and what education we might need to provide our service users so they feel comfortable and they're building trust with our providers to share some of this information related to their social determinants of health and sociodemographic factors. And that it's important that these data are actionable, that they are not specifically used just for the purposes of research, that they actually inform the care that's provided. And we've heard a lot of exciting conversations so far about care provision and how these data can inform that. Some of the key elements that we wanted to prioritize would be race and ethnicity, language, religion, disability status, and gender identity. Some of our THP focused workshop themes included addressing communication barriers, so thinking about language, thinking about how we might leverage EPIC and specifically the MyChart function, which is the patient portal or people portal, which can also collect patient-reported outcome and experience data, how we can continue to build trust and continuity of care with our service users. It's important that we avoid assumptions, so we shouldn't just assume something about the people we're serving, and people don't want to have assumptions made about them. We really need to intentionally ask and create that safe space for that to happen. And really, most importantly, that we prioritize trauma-informed and patient-centered approaches. So some of the recommendations that emerge from this work is that we collect data as much as possible before care so that it can inform care. And this would be more of an asynchronous data collection opportunity with data collected in advance of a planned outpatient clinical appointment, that any data provided should be voluntary and optional, that data collected before care should include multiple choice options and then open-ended questions, that there should be those sort of structured and unstructured data fields, that in-person data collection should be in a safe private setting with the choice to provide verbally or in writing, that we collect data only one time and share this across teams to avoid repetition. And we can do that within our hospital through our integrated health system. When we talk about bridging into the community, that's where it's more challenging given the disparate systems that don't communicate effectively with each other. And that it's important to consider how the data being collected, how it's collected as opposed to who is collecting the data. So it's how is just as important as the who. The who was really anyone who was meaningfully involved in that clinical care encounter, and the how really was through the multiple opportunities in using the trauma-informed approach. So in our organization, we're now going to be focusing on acting out these findings. So we did a deep dive into this one inpatient area, which is our labor assessment unit. And we did a deep dive through interviews and patient journey mapping in 3 outpatient clinical areas. One is an extended midwifery care program. One is a developmental disability serving program for children and adults. And the other program involves family violence and intimate partner violence. And so we will be in the next few months planning to actually implement the pilot data collection opportunity in partnership with our teams in Women's and Children's and our digital health committee and EPIC teams. Okay, I think that I did that and my dog did not interrupt, so I am finished. Thank you all again for your patience. I'm gonna have to find Tim in a moment, but I know that we are short on time, so back over to the Born team. Thank you very much.
Thank you very much, Dr. Zenlea and Dr. Fierheller. I think that was very informative, and thank you so much for sharing that model for co-creation with community. I think this is very inspiring. So we would like to now turn the floor over to our audience and give you an opportunity to ask a few questions. So we currently have one here in the chat. And the question is for Alexia. So could you share with us if and how you might share what you've learned about your client's specific needs with other in their care circle beyond ancestral hands? And do your clients want or ask you to share what you know with others in the care team outside of ancestral hands?
Okay, I'm seeing if I can open up the chat here to also look at the question.
It's in the, yeah, if you open the Q&A section, you should be able to see it.
Okay.
I'm happy to repeat it as well, if that's
Yeah,
helpful.
can you?
Yeah,
No, I
of
see
course.
here. I'm gonna sure.
Of
Go ahead
course.
and repeat it for me.
I will. So we're wondering if you could share with us if what you learn about your client's specific need, how you share it with other healthcare provider beyond ancestral hand, and do your client want or ask you to share that information with health or care team outside of ancestral hands?
Yeah, so our clients do want us to share the information. They want to, they really want to be seen, right? And so walking into an office and not having the time to be able to tell their story that reflects the reasons why they're making the decisions that they are, which in some situations can look like somebody who's not compliant, right? Even the types of words that we use to describe clients and how they make decisions really, and how that's documented in their health records makes a big difference. So when we can, get on the phone and talk to other care providers or partners that we are working together with and say, this is what's going on in this person's life. This is the trauma that they've experienced. And it's happened many times where I've had clients who have had significant trauma. Their obstetrician has not known anything about it, and they are declining, test and care after and doing things that one would deem unsafe in their pregnancy, but they're making decisions that are in their best interest. And so I think it's really important that that we continue to share the information with client consent and being aware, but they want everybody to know. They don't want to have to share it every single time and open up that can of worms or open up that trauma or that, that bandage with every encounter that they have.
Amazing. Thank you. And there's some interest also in having the link to the report that Dr. Zenlea shared, the community report. If we don't have the opportunity to share it here, we can circulate it later by email with our people in attendance today. If
I put it into the question, and I wasn't sure where, because I know the chat wasn't working, so I did put it in there just so you can find it, but we're happy for you to share. And again, I know we're short on time, and we did that really quickly, so people can also reach out to us directly.
Thank you so much, Alicia.
Sorry, Diane, do you think that you could actually reshare it in the Q&A? I just didn't see it come through.
I just tried. Let's see. I don't know if anyone got it. Oh, it's there at the bottom for Diane.
I put it should be the last thing that was posted. It's under Sarah Hamilton's, if you scroll right to the very bottom.
And I just reposted it at the top of the Q&A. It should be
there.
Okay,
now. Perfect.
Thank you so much.
And please reach out.
I couldn't type fast enough, Ian and Diane. Thank you so much for your presentation. But I actually had a question about you mentioned the complexity, I think in the same vein of like sharing what we know that Alexia just answered, the complexity of like asking once and sharing. And I'm curious what's come up in the conversations you've had with so many people about how people want to govern that, especially outside the walls of THP. So if it's collected within THP, what are you thinking about how you manage what you want to share, what patients want to share outside?
It's a really great question. And I was it is still an ongoing conversation when we think about governance and data sharing, especially with our community partners and organizations. And I was on a call this morning with someone from the region of Peel Public Health, and they're wanting to pull together, a grant where we can all come together across systems and look at that governance. So I think it can be easier when it's within, the care team. When we're thinking of like from that medical model, it becomes a lot more complicated when we're thinking about all of those community partners and organizations, whether it's education, whether it's public health, whether it's Children's Aid Society, how we're sharing that. So the region that we work in is very, very interested in building out a community data warehouse, building out a governance structure. To be continued, I'll say. I think that's the biggest piece, is that it becomes a lot more complicated, but there's a lot of people that want to make sure that this work moves forward, but it's building what that governance will look like. So to be continued, but I'm really hoping that we can move beyond just a framework. This is what my partner from Peel Public Health said this morning, beyond just reading about what a framework could look like and actually actioning it out.
That's incredible. I would love to stay close to that and hear more, Dianne, because I think we have an opportunity in Ontario to be leveraging some of our registry authorities as well to bring data together from beyond research, as you mentioned, right into the care piece. And I think as you all are certainly leaders in that space and Peel, others can learn from that as well. And maybe we can build some infrastructure that allows us to do that between communities. So that's very exciting, very interesting. Thank you for sharing.
Yep, and I'll just follow up with just one last comment. I know we're out of time. That through our workshops, we were really intentional, and through our conversations with our digital health committee, which is really stewarding this work at the executive level, about the difference between collecting data at the point of care or to inform a care experience, and data to be used for population health purposes. There's for Born and the Born information system. These are just, and the prescribed registry work that I've been doing alongside you with the pediatric diabetes registry, it's similar but different. And so we really wanted to be intentional through our workshops about understanding whether people might be comfortable with us collecting data that may not impact their clinical care right in that moment, but could be used to inform that population, the care of populations and communities. And so that, I think, aligns with the conversation Dianne is having with public health. But we're really intentional in our workshops about teasing those two things out: clinical care, for clinical care to inform clinical care, and then for population health purposes, which may include later research. And think about how to consent people for that.
It's a broad continuum of use, right? That I think we barely tapping the surface in looking into how we leverage that. So definitely looking forward to learning more. Ian.
Thank you. Thank you, everyone, for your great questions. Thank you, everyone, for attending the webinar today. Merci, miigwech. It's really been a pleasure hosting you, and we really hope that this webinar has provided you with the information required to fill the survey as well. If you have more questions, please feel free to reach out. Our email is just here on the slide. We'll be happy to get back to you with more information that you're looking for. And just prior to logging off, if you could take just a few minutes to fill a short webinar evaluation questions, as it would help us improve our webinars moving forward. Wishing everyone a wonderful rest of your day, and we're excited to continue collaborating with our care partners across the province. Have a good day, everyone.